Thank you. And the recording will be posted on the committee's webpage shortly after the meeting. And Pam McEwen, FTAC Liaison to the Universal Healthcare Commission, will now call the meeting to order. Pam?
Thanks, Angela. Good afternoon. Welcome, members. It's now 2:02 p.m. and I'm going to call the FTAC November 9th meeting to order. We'll begin with a land acknowledgement. I'm in Winthrop, Washington today on the traditional land of the Mettau and Colville Confederated Tribes, past and present. And we honor with gratitude the people who have been stewards of this land through generations. And this calls us all to be better stewards of the land we inhabit. I'd like to give a warm welcome to everyone joining us today for the 6th FTAC meeting and our last meeting of the year. I'll start with an overview of the agenda. As always, we'll begin with roll call. And we'd like to use this, as we usually do, as an opportunity to let committee members get to know each other better. So the question you get when your name is called is, what is your favorite part of fall? We'll be voting on to approve the September meeting summary. We will have public comment. Then HMA will share where we are with the work plan and updates from the Commission's October meeting. We're going to begin our discussion on Medicaid, which will take place over this meeting and the January meeting. First, we'll hear from Commission member Joan Altman and also Melissa Rivera on the Washington's Medicaid enrollment process. Then we'll hear from fellow committee member Roger Gantz on an overview of the Medicaid program. We're going to have time for committee discussion. As always, I encourage FTAC members to ask questions and provide feedback to help facilitate today's discussion. I'm going to turn it over to Angela to go through roll call. Angela.
Thanks, Pam. I'm going to call on members by their first name, and please, when you're called, remember to answer what your favorite part of fall is. So Pam, we'll go ahead and start with you.
Okay, well, you didn't ask me my least favorite part, which is the time change, but I have to say it's fall colors that I like the best.
Beautiful. I know that time change is really tricky. Stinker every year. Okay, we'll go ahead and move to Christine. Oh, you're on the East Coast, Christine. What is your favorite part of fall over there?
Yeah, I guess it's Halloween, but I like fall. I like every aspect of fall.
Oh, nice. I know I'm always sad when Halloween is over. Okay, David.
Good afternoon, everyone. My favorite part of fall is now the salmon run. I went salmon fishing this year for the first time.
Oh, did you? Where'd you go?
Went on the Skagit River and then a little bit out in the Sound.
Oh, beautiful. It's so special. I just went to, is it Meadow Creek Trail in Olympia and saw it over the weekend. It's just beautiful. We're so lucky that that's so nearby.
Yeah.
Okay, Eddie.
Hello, everyone. Yeah, my favorite part is probably with Pam on this one, it would be the fall colors and pumpkin spice. And least favorite is the daylight dwindling.
Thanks, Eddie. Esther? Esther? Okay, Ian? And Ian, let me know he won't be able to attend, but just in case, Ian. Okay, Kai.
Yeah, hey everyone. So favorite part of fall is walking in the arboretum and seeing all the different changing of the colors of the trees. So
beautiful. Thanks, Kai. Bob.
Hi, everyone. I actually like the change in temperature. I like change generally, and just the fact that it's a little chillier is actually a positive thing for me. I just get a fill up a hot water bottle, stick it in the bottom of my sheets, and that way I'm toasty as I crawl into bed, and it's a nice warm feeling. So that's my guilty pleasure.
The cozy of fall is your favorite.
Yep.
Very nice. Thanks, Bob. And Roger.
Good afternoon, colleagues. I guess I'm consistent with everybody else. It's a combination of the fall colors and the opportunity to go for some nice hikes in the Olympics and the Cascades to really embrace those set of colors.
Oh, beautiful. All right. Well, thanks, everyone. I will go ahead and turn it back over to you, Pam.
Thanks, Angela. We're going to go now to the approval of the meeting summaries. This is under the second tab in your materials. And the recording of the last meeting is posted on our website. We're going to use the consensus process. And I'd like to ask first if there's any discussion of the meeting summary or any proposed changes. Roger?
Yes, Pam, if I might, and this appears on page 4. It's the section is talking about FTAC members voting on recommendations. And there's a sentence in here, this says, one member suggested that the commission work with the Oregon Universal Health Plan Governance Board to influence federal legislation on ERISA. That was, I think, my statement. I would like to amend the suggested to recommended.
Are there any objections to Roger correcting the wording of his own statement? I didn't think so. All right, anything else? Any other comments or corrections? All right, all in favor, please say aye.
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 Any opposed? I think we are approved by consensus. Next, we'll move on to public comment. Okay, committee members can find written public comments under tab 3. And we will allow individuals to sign in to provide public comment before the meeting. And we will start with those who've signed up to provide comments. When you're called upon, please state your name and affiliation, if any, before speaking. We will be displaying a timer as a reminder of the 90-second time limit. When the timer stops, please stop your public comment. Angela, would you please start with the names of individuals who've signed up?
Yes, I can. So first we're going to start with Chris Curry and then followed by Lori Bernstein. So Chris, if you'd like to come off of mute. And again, folks, if you just remember that transition when you're promoted to panelist takes just a second. So, so Chris Curry.
Yeah, I hope this works.
Yep, you sound great.
Okay. A July OIG report estimates that managed care organizations denied 1 in 8 Medicaid pre-authorizations in 2019. In Washington, Molina denied 19.3%, Amerigroup denied 14%, United Healthcare denied 11.5%, and Coordinated Care denied 8.4%. Since the state totals of pre-authorizations are not listed, we can't translate percentages into actual numbers of denied payments, but we can assume it's unacceptably quite high, especially when the denial rate for Advantage plans is much lower and traditional Medicare's is near 0. Besides numbers, we need to know what these people do for treatment when claims are denied, what their doctors think of the situation, and how much money is being wasted on these poorly functioning MCOs. Clearly, a more robust evaluation of managed care is needed. So instead of spending your time at these meetings on such things as the mechanics of how Medicaid works in theory, I would suggest you relegate this and other background presentations to recordings to be viewed at other times, and spend your far too limited meeting time discussing important issues like the one I just raised. Thank you very much.
Thank you, Chris. Next, we'll hear from Lori Bernstein, and after Lori will be Roger Collier. Lori, if you'd like to come off mute, please.
Sure, thank you. Actually, I can speak to the issue of denials and prior authorizations. I actually am on Medicaid, and when I showed up for my appointment to get the new booster, I was told that my insurer, Amerigroup, required prior authorization. I went to the trouble of getting it from my PCP, who had to go through 2 different attempts to finally get it to Amerigroup, and they still denied the payment. The letter they sent to me said that the vaccine isn't medically necessary and that it's not covered under my pharmacy benefit. So that was 6 weeks ago. I've appealed it. I don't hear back from the HCA. I don't know whether this is an issue with all Medicaid MCOs, that they all refuse coverage, but this would not be a problem if we had a state-based single payer system. Secondly, the UHCC asked the FTAC to answer 5 specific questions related to Medicaid. I've looked through the meeting materials, and today's presentation looks to be a general overview rather than a detailed answer to each of these questions. And I'm wondering if this is the best use of the Commission's limited time. Along with that, the UHCC in their last meeting committed to having staff highlight key action items in the summary of the previous meeting and sending out videos of presentations in advance so commissioners can come to meetings prepared for discussion. In addition to that, they agreed to lengthen the meeting time from 2 to 3 hours. I wonder if these are steps that the FTAC is willing to take. Thank you.
Thank you, Lori. Next, we'll hear from Roger Collier and followed by Marcia Stedman. Roger?
Okay, good afternoon, FTAC. Later in this meeting, you're going to hear details of the Section 1115 waiver process that theoretically permits states to modify the Medicaid programs. It's something that theoretically could allow inclusion of Medicaid eligibles in a state universal care system. However, as you will also hear, I hope, Section 1115 does not give carte blanche to states. The feds retain veto power over states' proposed changes, and they can, even without rejecting a state's proposal, as I'm sure you know, delay proposed changes almost indefinitely. That's a Fed specialty. My own experience includes managing Medicaid consulting projects for both the feds and for some 20 state Medicaid agencies. Based on that experience, my conclusion is there's virtually no chance the feds will approve a waiver to allow Washington to transfer 2 million state residents from a functioning Apple Health program to a non-existent, untested universal system. The one hopeful possibility, however, is that the feds might be more amenable to a future merger of Apple Health into a future system that's already demonstrated the state's ability to combine programs, as I have previously proposed. Thank you.
Angela, you're on mute. Could you repeat that?
Thank you so much. Marcia Stedman next, followed by Raleigh Watts. Marcia, you let us know that you were having some audio difficulty, but I'm hoping you can come on now. Marcia Stedman? Okay, Marcia, if you're having some technical difficulties, please do send your the comments you had prepared today to the FTAC inbox, and we'll distribute those to members. We'll go ahead, Raleigh Watts, followed by Catherine Lewandowski, please.
Hello, colleagues on the FTAC. Thank you so much for your work. Today's agenda is a deep dive into Medicaid and Health Plan Finder. What we're talking about today are health carrier administered programs. Most of these are out-of-state, profit-making corporations. Note that Molina, in the last quarter, reported a $300 million profit, and their CEO, after receiving an 11% raise, made $22 million in annual salary. These profits are the result of getting state tax dollars as income and then restricting care to state residents. In its baseline report, the UHCC identified various models. Health carrier administered programs were Model B, but remember Model A, state administered programs. My comment is this: please assure the FTAC spends sufficient time understanding the benefits of Model A single payer approaches. One example of Model A is the Washington Health Trust. A state-administered program saves all of us money because we are not using our needed healthcare dollars to support Molina's and others' profits. Thank you.
Thank you, Raleigh. And finally, our last sign up is Catherine Lewandowski. Catherine, if you'd like to come on.
Sure, thanks. Catherine Lewandowski, registered nurse here in Washington, and I'm the vice chair of Paul Washington and treasurer for One Pair States. I wanted to say at your last meeting in Bill Kramer's discussion, he noted that based on recent research, large employers nationally are paying between 200 to 300% of Medicare with variation for health benefits. Is there an argument that a universal healthcare system will relieve some of this pressure for employers? And it made me remember some of the benefits of a single payer healthcare plan. For background, I used to work for a very large religious-based healthcare system, and they were self-insured. So it behooved them to encourage employees to use their own hospital and clinics. In that situation where the employer is not only the insurance provider, but also the healthcare provider, it makes good business sense to make payments of 200 to 300% of Medicare, because you are essentially transferring employees' healthcare dollars from the employee's healthcare benefits package to the healthcare provider's arm of their business. The point I want to make, though, is that we know that we can save money with a single payer plan because our large employers have the benefit of their size to be self-insured. And why do they do this? Because they know that administratively it saves money to have just one pool of dollars and just pay for their employees' healthcare, basic healthcare needs. They also do this because they realize that they save money over purchasing healthcare on the open market. Our smaller companies do not have that benefit of size and are therefore stuck having to purchase their employees' healthcare policies from the marketplace. Many of them cannot afford to do that anymore, because even in the light of record profits and for-profit entities are not satisfied. They continue to ask for unsustainable premium rate increases. And I'll put the rest of mine in writing. Thank you.
Thank you, Catherine. Okay, let's call for folks to raise their hands if they'd like to provide additional public comments. We've got a couple more minutes left and want to open it up for folks who didn't have a chance to sign up. Just give it another minute here. Okay, I don't see any other hands, Pam, so I think we can go ahead and move on.
Okay, thanks, Angela. I want to thank everyone who took the time to comment today or submit written comments. We really appreciate it. It's a really important part of our process. Right now, I'd like to welcome back Liz Arjun from HMA, who will share with us where we are in the Commission's work plan and give us some updates from the Commission's October meeting. You can find the work plan under tab 4 of materials. Liz?
Thanks, Pam. Hi, everybody. Just to kind of reorient everyone to our, I can't believe it's the first year, almost finished a whole year of FTAC. So congratulations to all of you and a lot of great work this last year. Here we are in November. We've talked about Medicare. We've talked about ERISA, provided some great guidance to the Commission, which we'll briefly touch on in a minute. But here we are in November and starting our conversations about Medicaid. We anticipate, there were a couple comments and public comment. We anticipate that this is the first of a couple of conversations on Medicaid. It is a quite expansive topic and very different from the topics that we discussed earlier with Medicare and ERISA in terms of the spread and potential implications about decisions. So that's where we are today. The final UHC meeting is in December. And as Angela and Pam mentioned, at the last UHC meeting, you can go ahead to the next slide, Angela. We started to preview with and discuss with the Commission what the work plan for 2024 should look like. There was, thanks to the work of a lot of advocates this last year, there were additional resources allocated to the Commission for 2024. And one of the questions in front of the Commission was how would they like to expand their time together? So they did decide that they would like to extend their existing meetings to 3 hours and continue with the bi-monthly cadence. There was a kind of a debate around if it was better to meet monthly and have shorter meetings or continue with the current cadence and extend. They decided to go ahead to having a 3-hour meeting. And a question for all of you about the work plan for 2024 is, would FTAC like to take a similar approach and expand their meetings to 3 hours? And is our preference around doing these in the morning and the afternoon? We realize that this is a group pulling from across the country, and it may be challenging to meet in the evenings for some of you. So this is important just because we're in the process, HMA is in the process of working with HCA staff to design the work plan for next year. And we want to just get some of the logistics sorted out. So I think I just want to pause real quick and see what folks think on this. or preferences.
But as I can say, oh, Pam, were you talking? I think you were on mute.
David?
Oh, go ahead, David.
Oh, okay. So, just in my experience, I think the 2 hours has been sufficient for hearing experts talk and some initial debate or discussion. It's nice to have a little time lapse and then be able to circle back and react, or maybe even come back together to talk about, well, what would the actual recommendation then be to the commission, which we've handled via email. If there were a way to have that third hour be a follow-up hour that's spaced apart in person or face-to-face, that might be helpful from my perspective, as opposed to a 3 hour long meeting.
Okay. I would jump in to say that I think 3 hours is a long meeting. And I think I would, if we need extra time to discuss, I'd, prefer to schedule another interaction. Yeah.
I appreciate that. I think it's, this group definitely, it hasn't felt as time crunched as I feel like some of the UHC meetings have. So that's really helpful. Others, any differing opinions? You feel like this is enough time? Roger?
Thank you. I support the notion of having more time. I'm hearing my colleagues say to stay with a 2 hour session, and if I'm hearing correctly, would be is maybe the other month or time thereafter, an hour, let's say in the following month, further discussions on a given topic. If that's what I'm hearing from my colleagues, I would certainly support that concept. And again, the key to me is really to have more time to have deliberations on a given topic, particularly as we're trying to put together our recommendations and feedback to the commission. I feel like we haven't had enough time for that, and this additional hour could be structured to accomplish that.
This is Angela. Thank you all, because we realize, when you volunteered your time for this, it was you had the impression this was going to stay, bi-monthly. And I want to make sure I'm hearing right too, that you're saying if you feel like you need more time, then folks are open to having another hour to follow up, but that there's maybe some flexibility that we don't need to book those additional times outright, that maybe we want to wait and see what folks think if we need additional time. Is that right? I'm seeing some head nodding.
Angela, can I, for clarification, are you saying that you would not schedule the time in advance?
Well, I'm wondering if it's helpful to schedule it in advance, and that people are flexible to, if we don't need it, we cancel it, or how they'd like to do that. Because I know all of you have other things going on and don't want to just kind of do ad hoc all the time.
Yeah, I'm a big fan of giving back the time rather than trying to find on relatively short notice.
Got it.
So correctly, that what's being suggested to Ms. Roger is that we would schedule the additional hour, so let's say the following month, for sake of discussion, and it would be on our schedule. If we don't need it, then
cancel it.
But we would have it otherwise scheduled for us. Is that correct? Which I think is a good idea.
That's what it sounds like.
Yeah. I think that it's possible we could be of more service to the commission members if we had a chance to come back and really take a little bit of a deeper dive into the recommendations right before the meeting and kind of confirm that's where we are and make modifications. So I like that idea.
I see Kai's hand up.
Yeah, so I think to Roger and Pam's latest point, I think that if the issue is the limitation of time for making recommendations, could it be that those can be done on those off months in the written form? Right? We have information and discussion during our 2 hour time periods, and then we have requests from Pam and you all to provide feedback in a written form afterwards.
do members have any thoughts on Kai's proposal there? Eddie, you have your hand raised.
Oh, yeah. So I think the current format in the afternoon works well for me. If you did extend it, would it be on the beginning or the end of the meeting? Because then it would get a little bit late because I have kids and such. So just the current format seems to be okay for my schedule.
So it sounds like we're focused on doing 2 hours, not 3, right? So we're going to stay with 2 hours, and Eddie's just raising again this issue of, do we need to consider moving our meetings to the morning? And I think there's two, Bob, not for you. It doesn't matter for you. Christine, you're on the East Coast, I know.
Yeah, I prefer to keep as is. I
Okay.
worried if we moved it, it would conflict. Yeah.
Okay, right, that was easy.
So let me see what I'm hearing though, to clarify again, is that we would schedule in the off month, prior to the other meeting, an hour
Yes,
for us.
yep,
If we don't need it, then we can obviously
Cancel.
cancel. We'd have formally scheduled.
yeah. And likely it would be prompted by probably the kind of interaction that Angela has with you when she sends like a memo or a review. If there's something that people really need to hash out rather than via email, if it's better to have a conversation, then we would do it then. Okay, so we're gonna stick with 2-hour meetings at the same time. We'll schedule 1 hour in the off months as a placeholder to use if we need it. Perfect. Great. The other piece that I think is relevant, so from last month's meeting, it's relevant to the work plan, is the transitional solutions. You all provided a lot of great information earlier this year, and the commission did settle on a couple of areas that they would like to spend their time on. If you'll recall, and we don't have a slide that shows this, there were a number of buckets, but one was affordability. On the end was I can't remember the other end of it, but they settled on coverage, enrollment, providers, and purchasing, with the recognition that issues around affordability are actually being addressed in another venue right now. The Office of Insurance Commissioner is doing a report on this, and we'll be making sure to bring that over to the commission. Roger, I saw your hand again. Did you have something?
I'm sorry, excuse me, I didn't mean to be doing, I'm trying to make my system work here. My
Oh, it's
apologies.
okay. I was having my own fight with my computer earlier, so I understand. So in any event, just want to share that we will be building that into the work plan, focusing on those topics over the course of 2024. The final piece, or the main piece from the commission's October meeting, was the ERISA recommendations that you all made. The commission agreed with the guidance from the FTAC that it should be revisited once additional elements of the system, such as benefits, reimbursement, are developed by the commission. Anything else, Angela or Mandy? Roger, I know there's a couple folks actually from the UHC on this call who were part of those conversations, and I don't know if any of you want to chime in. Joan or Jane? Okay. All right, Roger?
So Liz, if I might, in those 3 bucket areas that the commission said to go forward with, there were a variety of recommendations, proposals, some of which FTAC provided to the commission. Of course, those are the commission itself. Would you anticipate that the commission in its developing its work plan will kind of go into each of those thematic areas, if you will, and draw upon specific ones that will then be brought back to us for further development?
I think as they relate to some of the decision making that you all are doing, or deliberations that you're having, I think they felt there was a lot of opportunity for some of those particular bucket areas to be related to some of the things that FTAC was going to be focused on next year. They just selected the large buckets. They didn't go into the details on the specific policies. So I anticipate that what will happen is we'll lay out the work plan and talk about some of these and see how we can line it up with the work of the FTAC. And probably the first pass at it will be kind of looking at the big list and where do you want to dive deeper? And how does it relate? What are the transitional solutions that could emerge from where you're trying to go in longer term design?
Okay. Thank you. And if I might add, quickly, as you mentioned in the area of cost containment, I would just like to remind our colleagues again that in Washington, there's the Healthcare Cost Transparency Board that does have a major charge at one of identifying areas upon which cost containment can be focused, and has begun that process. So I would encourage us at times, both us and the commission, as we're working through some of the areas of cost containment, to continue to have close coordination with them, and quite frankly, maybe feed them ideas, or they can share with us areas they're developing. So we're in coordination with each other.
That's a great point, Roger. And that was a big part of the conversation in selecting the buckets, was recognizing that not just the OIC work, but also the Cost Transparency Board. There are other venues where some of these conversations are happening. I think the public option work that the exchange is doing, that we need to do more to make sure that everyone is kind of aware of the other moving pieces and how they relate to the work that's being done here. So thank you. Anything else before we move on? Okay. All right.
All right. Thanks, Liz.
Thank
you got
you.
a lot. You got in a lot into that very short presentation. So we'll look forward to hearing more about the work plan early in the year. As Liz mentioned, this is going to be the first of 2 meetings that we'll be discussing Medicaid. And I just have a couple comments before we dive in. But my notes say that Medicaid is very complex, which upon reflection, I would say that everything in healthcare is complex. In fact, if you think it's simple, it's because you haven't learned enough about the topic yet. So we went through Medicare and ERISA, obviously complex topics, but what is really different about Medicaid, kind of looking at the same set of issues in terms of, coverage and who's included, is that unlike Medicare and ERISA, the state has a great deal of latitude when it comes to Medicaid. The authority and responsibility for Medicaid are shared with the federal government. And although Medicaid in Washington, the program has its challenges, there have been some huge successes in Medicaid in our state. There's a lot of good stories to tell, but there's also some interesting opportunities as we start looking at where we might go. So I think it's going to be interesting to kind of review what those opportunities could be as we look at what the federal limitations are, and the potential for the Universal Healthcare Commission to develop maybe possibly a clearer path forward with respect to Medicaid. Our speakers today are going to help us identify some of the existing enrollment and coverage processes and the rules around Medicaid, as well as where we might want to take a deeper dive in our next meeting. So I'd like to welcome our speakers. We have Joan Altman and Melissa Rivera, who will present on Washington's Medicaid enrollment process. Members can turn to tab 5 of the meeting materials for Joan and Melissa's presentation. Along with serving as a member of the commission, Joan Altman is the director of government affairs and strategic partnerships for the Health Benefit Exchange. Melissa Rivera joins us from the Healthcare Authority as a lead policy manager in the Office of Medicaid Eligibility and Policy. So thank you very much for being with us today, and we look forward to hearing your presentation. Joan.
Thanks so much, Pam. Appreciate it. Hi, everyone. Thanks so much for having me. Excited to sit on the commission and benefit from all of your good work and analysis that makes our jobs much easier. So thank you for your guidance and recommendations. We extensively study them and discuss them when they come to us. I have just a few minutes to give you the highlights of some of the things that distinguish Washington State, particularly as it regards to, in regard to how the state helps enroll people into the Medicaid program. My focus is the MAGI Medicaid population. You're in good hands with Melissa, who can walk through the classic side. So I'm just going to provide some key highlights and hope that if there's an area of interest that you'd benefit from more detail, feel free to invite me back, and we'll go from there. The next slide orients you at a high level to some of the topics I was asked to present. We'll see what we can get through in 7 or 8 minutes, and Angela, keep me honest on time. The next slide starts us with just the highest level look of Washington State and the Affordable Care Act. I think this is probably broadly known in this group, but Washington is unique in a few ways. We're one of the states that both expanded Medicaid and set up a state-based marketplace under the Affordable Care Act. We used to be one of few, and we're an increasing number of many. There are now 19 state-based marketplaces, but when I was at the exchange when we launched for 2013, we were one of only just a handful. And in addition to being a state-based marketplace, we are one of an even fewer number who have an integrated platform, meaning that someone can come in and have their eligibility determined for the whole suite of Apple Health programs minus Classic. They can get referrals over to the Classic program, and then they can also be at the same time screened for private coverage and all the federal and state subsidies and state sponsorship programs that are available on the private side. So we've seen the benefit of that integrated structure, particularly during for the population that churns between Apple Health and QHP or qualified health plan programs. We've also seen the degree to which we can do improved outreach by leveraging our state-specific data in real time to reach out to people during the Medicaid unwind and otherwise. The next slide orients you to where we are, where we sit. I work for the exchange. We operate Washington Health Plan Finder. That's our online marketplace. Every way in which a customer is supported with our technology and our tools. They're also supported in community through an extensive grassroots network, over 3,000 assisters and brokers and tribal assisters, and also by a customer support center that fields calls on both Medicaid and qualified health plan and subsidies. So again, a family who's a mixed status family, meaning they have people enrolled, maybe the kid is on CHIP and the parents are on a subsidized private coverage plan. That whole family can be treated as one unit and enrolled together and at the same time, which again, during the unwind has been critical. You've heard, we serve over 2 million people. It's more than that at any given time. I think people come and go, both from the Medicaid marketplace and the qualified health plan marketplace. It's 1 in 4 if you count our entire state population. It's 1 in 3 if you remove the under 65. And for several counties in the state, it's 50 to 60% of their non-elderly population is using Health Plan Finder. So to say that our broad has really reaches broad would be an understatement. By far and away, the highest number of people who come through our system are Apple Health customers. You can see 2 million on the Apple Health side, 200,000 plus on the qualified health plan side. So again, you get screened for the Apple Health programs, you get screened for federal premium subsidies, you get screened for state subsidies, and we also connect you to third-party payer or premium assistance programs that cover your premiums beyond what the available subsidies do. The next slide shows you, again, some of who we serve. A lot of our population, we have a very mixed income population in the exchange. Our lower income population or people who are between jobs or have lost their employer coverage or who have been impacted, particularly during COVID and recession, with people who are qualifying for Apple Health. We also have people who are working minimum wage jobs or above who are over income for Medicaid and are eligible for federal and state assistance. We draw down about $700 to $800 million worth of federal subsidies to help customers afford their coverage, and that's just on the premium side. So we also have a $55 million a year state subsidy program that complements the federal subsidies. So again, healthcare is expensive. Costs are increasing. We're sort of maximally leveraging what we can that's available at the federal and state level to help make it affordable, at least in the short term. You asked for a focus on Medicaid, so Melissa will speak to this in greater detail from a programmatic perspective, but at the highest level, Washington Health Plan Finder supports the 2 million plus folks now who are on the Apple Health programs by essentially facilitating their plan selection and enrollment, by generating the renewals and the notices, by processing all the renewals behind the scenes, and then also for helping with the outreach and enrollment assistance through our Navigator program and our customer support center. Everything programmatic, that is Melissa's job. Everything about the actual administration of the program, it's obviously state administered, and that's what our colleagues over at Medicaid do. Next slide. So I think there's who we're serving and who we're not serving. So I think, since the launch of the exchange, the uninsured rate went from 15 to 5%, which we were all incredibly proud of. Of the remaining 5%, we know that a quarter of them are people who are undocumented. We know that people who are undocumented have used the exchange for several years now to get connected to sort of limited availability or population-specific Medicaid programs, but no one has been able to enroll in the private side of the house due to federal restrictions. That's changing this year. Right now, we've had a few hundred people come through already in the first week of open enrollment and sign up. We got a waiver from the federal government to waive that provision so that anyone, regardless of their immigration status, can come through and sign up for private health coverage and benefit from state subsidies. And then it's a bit of a two-phase approach in Washington. We also got direction from the legislature to expand Medicaid for the up to 138%, and that'll be happening later this summer. So right now, today, people who have previously been able to access coverage can. And again, by signing up for a Cascade Care plan and benefiting from the Cascade Care Savings, which is our state subsidy, hopefully we're putting coverage within reach for folks for the first time. The next slide shows you a little bit about how we did that. Again, it's called a 1332 waiver. It's not as sexy as the 1115 waivers and all the waivers Roger will tell you about later on, but don't sleep on the 1332 waiver. It does a couple of really interesting things. It lets you waive parts of the Affordable Care Act that you don't like as it relates to within limits within the exchange market. It also lets you draw down additional federal funding. So if you all and the commission were to implement a state innovation that helped lower costs of the federal subsidies, the 700, 800 million that comes to the state, if we do something through, let's say, our public option program that lowers premiums, and we demonstrate that successfully to the feds, then the amount that which you lower the outlay for the federal government, you can capture as a state and bring back to support affordability programs and to further expand coverage. We were asked to look at that over the interim, and that's one of the reports Liz mentioned that we'll be putting out in early December. So again, happy if there's interest to come share more about Cascade Care savings and how the waivers can be further leveraged. But we were the first in the country to do it. We have some states who are lookalikes and coming on board. So we'll see where it goes from there. Next slide, please. Here's the Apple Health expansion that's coming in July. So starting July of this year, anyone who's undocumented enough to 138% of the federal poverty level and uninsured can get a $0 zero cost sharing plan. Anyone who's over 138% can get a qualified health plan or dental plan with a state subsidy. And we'll obviously be helping move people to various programs as needed. Okay, we're switching now to sort of pivoting to Health Plan Finder and what it does. So you can see the Apple Health programs we screen for on the upper right. I've already talked about mixed eligibility households, and also most probably notable for this group that anyone who comes through and gets a Medicaid eligibility determination is automatically enrolled into a Medicaid plan. So you have the option to select a plan. The lower left shows you what the screens look like for someone who's picking a Medicaid plan. Otherwise, we automatically enroll you. And again, the lower right graph just shows you what a mixed status family looks like. So there you have, I think, Carol and Mike Brady. It's funny. That's what happens when you ask for screenshots and then you don't look at the names. But Carol and Mike Brady and their son, Greg, and their daughter, Marcia, are in this example. And you can see that Greg qualified for CHIP. So anyway, that's an example. Next slide, please. We get asked a lot, especially when we were first launching the exchange, sort of, oh, so it's just a website, like it's a fancy website. It's like, well, that is true. It's an incredibly fancy website. But I think what we've learned over the past 10 years, we got $600 million in federal grants to build this interconnected system that combines 50 plus federal and state databases so that we can provide people real-time eligibility that verifies income and verifies citizenships and does things that are important to people, maintains security, allows for identity proofing. There's sort of extensive behind the scenes work that goes into building something that can both screen for eligibility from multiple programs and then also refer to eligible programs, then also draw down federal assistance and communicate that information to carriers. The next slide shows, this was a top of mind list that I made. I'm sure people at the exchange would be horrified and have lots of other things, but here is the sort of graphic depiction of that. So again, you can see Health Plan Finder and our customer support features. To the right are some of the federal databases that we connect to, pass information to in real time. And then on the left, you can see the Washington state agencies. We connect through HCA to Provider One. We connect to DSHS. We refer for walk-on. It's connected to ACES ES. We also connect to all of the health carriers that participate in the exchange and pass information there.
Joan, are you close?
I am. That's the last couple slides are just rolling through. I'll just direct you to the report that we've done. The next slide shows you sort of how things have been shaping up with the Medicaid unwind. The next slide has a link to the report that we put out recently that may be of interest, essentially showing that the difference that having the platform has made in Washington and how we've been able to capture essentially 30% of the people who've lost coverage during the unwind have come back in and regained eligibility, which is positions Washington well relative to the rest of the country right now as we're going through the unwind.
Thank you.
Melissa, over to you.
Okay, can you hear me? I muted myself.
Yes.
Okay, perfect. All right. So, hi, my name is Melissa Rivera. I'm with the Healthcare Authority, and I'm going to talk about the enrollment process. So go ahead and go to the next slide. So as you probably already know, so Healthcare Authority is the state agency for the policy and purchasing of all Apple Health Medicaid programs in Washington state. So for the purpose of eligibility, we divide it into two programs. So we talk about MAGI-based medical programs, and then we talk about the classic Medicaid programs. MAGI stands for Modified Adjusted Gross Income. So this is how the income is calculated to determine eligibility, and it's just basically how as close as the adjusted gross income that people see when they file their taxes. So next slide, please. So just kind of give you an idea here. So Healthcare Authority, we're kind of like the middleman. We work with DSHS and we work with HBE. So kind of when we talk about MAGI-based programs and classic, there's two ways, right? So we have people that are applied through MAGI-based. That's a majority of our people. That's people that are 64 years and younger. When they apply through it, they can either go through the Washington Health Plan Finder. They can call, they can go in person with a navigator, and they can help them apply online. They get real-time eligibility results. They can choose a managed care plan so that through the system. If they don't, the system automatically will choose for them, but the client can go back in and call and say, hey, I want to change my plan, and they can do that online or calling. If they want to talk to somebody, there's the call center. They will talk with Joan's team over at HBE to troubleshoot the online application. If they have eligibility questions, it's just a matter of transferring them over to Healthcare Authority, and the staff there helps them with that, or billing questions or eligibility. When we talk about the classic side, we are talking about people who are 65 years and older, or they're on Medicare, have a disability or a blindness. They go through the Washington Connections, or they can go in person at a local DSHS office. They can also call and request a phone interview. The difference between processing is it's an actual DSHS staff, right? That based on the application, they enter the information in the system, and then the system will then, determine eligibility. So that's the only difference, where it's an actual DSHS staff that enters the information versus over at the Health Plan Finder system, right? You enter it and you get real-time eligibility. DSHS Center also has their own call center, but again, a lot of times there's those transfer calls between us, HBE, so there's that constant communication between us and the two sister agencies. So next slide, please. So talking about eligibility, it's determined by what the client enters into the system. And so based on that, you know, the system, as Joan mentioned, there's, you know, it's cross-matched with the state and federal data sources, and then they get the real-time eligibility. Sometimes though, what happens is if the information they enter and it's incompatible, right? So the information doesn't match with the data and federal sources, there's a report that's ran, and healthcare authority staff actually look at that report. And so if they see some discrepancies, they'll call the client and try to get that information that they need, or, you know, send a letter. Next slide, please. And so, you know, there's constant churn. You know, there's always people moving in and out of state. You know, people get jobs, they lose their jobs. And so because of this, applications are accepted year round. So there isn't an open enrollment because of this. So usually when someone is found eligible, they're approved for a year. The only time it's the certification period is shortened is if, like, you know, after we approve them, there's some data discrepancies, or there's people that are turning 19 years old, or they start receiving Medicare. So depending, the programs change, and so the certification can change. You know, there's those people that are no longer a Washington State resident. So those are type of examples of where it would not be a year period. So next slide, please. And then just kind of giving a breakdown here so that people that are for adults 19 to 64, children, parent or caretakers, pregnant people, they would want to apply through the Washington Health Plan Finder. They can call, they can download a mobile app. It's called the Wall Plan Finder, and do it all on the phone. They can fax their application, they can mail it. So just several ways. Next slide, please. And then, so talking about Classic Apple Health, so Healthcare Authority contracts with the Department of Social and Health Services, so they administer the Classic side of the program. So it's 65 and older, people who are on Medicare, have a blindness or disability. So we call these the Classic Medicaid programs. So individuals that apply through this would go through the Washington Connection application portal. And so eligibility varies based on the household size, income, and then some of those programs require a resource requirement. However, the Medicare Savings Program no longer requires that as of last year, January. So that's good news. Next slide, please. And then, you know, how to apply for the Classic Medicaid programs. It's, you know, 65 years or older, people who have a blindness or a disability or on Medicare. They can go through the Washington Connection portal. They can submit a paper application. They can call and request a phone interview, or they can go in person to a nearby local community service offices and apply. And let's see, as far as enrollment, you know, so after the pandemic ended, we started normal operations as of April 1st. And so we started notifying clients, hey, it's time to renew your coverage. You know, we reached them by mail to giving them, you know, a heads up that it's time to renew their process. You know, all clients have the opportunity to renew their coverage prior to any closure. And then if for some reason it ends, they still have 90 days to go back and renew their coverage. Next slide, please. So, you know, as mentioned before, you know, we will send them a postcard, letter. They get phone calls, text messages, all with trying to let people know it's time to renew your coverage. If their benefits do close, they have the option of purchasing a qualified health plan. They can, there's the option of going through Medicare and the employer-sponsored insurance. Next slide, please. And then this is just like a visual. So 80 days prior to when it's time for them to recertify their benefits, they get a postcard saying, hey, have you moved? Are there any changes you need to make? Here's who you contact. 60 to 50 days prior to their certification period ending, they'll get a letter that says, hey, you know, based on your information, you're good to go for another year, you're recertified. If there's some data discrepancies, they'll get a letter with a red marked envelope that says you need to take action, we need you to come in, apply, make the changes. 50 to 20 days prior, the managed care organizations do their own type of outreach to get the members to enroll for coverage. Because of the pandemic, we have this CMS is allowing us so that when the clients report a change to the managed care organizations, the managed care organizations can actually fill out a form and email a special inbox that we have to let us know, hey, our members are reporting a change of address or phone number, and we can actually make those changes. So that takes it away from the client having to do that. We're working with CMS to see if that's something that we can go ongoing, because I think that's a really, that's something really helpful. 20 days prior to their case ending, they'll get a letter says, hey, you're going to close in 20 days. If by the 15 days prior, if there's still no contact from the client, we'll try and reach them via text saying, hey, it's time to renew your coverage, and a phone call. If it comes time to their benefits, they close, the client still has 90 days to come back and reapply, and there would not be a gap in their service. And a lot of times that happens, like sometimes they're still unaware, they'll go to their doctor's appointment. Providers have access in Provider One to see like it ended, and they can tell the client you were closed, for example, a month ago, and the client can go back in and apply, and they won't have a gap in coverage. Next slide, please. That's it. Hope I made it in time.
You did. You did an excellent job. You both did. So I think this meeting is an excellent test of whether we want to stick to 2-hour meetings, because we are really jamming it in. So I'd like to have questions, but I think we want to give Roger time. Before I move to Roger, I just want to note that one of the reasons it's important to spend some time understanding how eligibility and enrollment works is because some of these systems which we built could potentially be repurposed. And I know that the Universal Healthcare Commission is really interested in the potential for that as we look towards a universal system. It's kind of taking advantage of things that we've built that may be able to be used for larger or different populations. And I think there's already been proof that we can do that within the exchange and the collaboration with Healthcare Authority. So thank you for the presentations. Roger, I want to turn it to you. We are so grateful to you to be sharing your extensive expertise on this overview of Medicaid. And I want to note that we are pressed for time, so we're going to try to wrap it up so that Liz has enough time to take us through the questions that we want to respond to and develop for the Health Commission. Thank you. Roger.
My apologies. I lost connectivity, so I had to reboot everything back up again.
Oh. That seems to be a theme for today.
Where is he? Angela, would you be kindly help me to kind of walk through the slides as I go through them? Okay, yeah. Okay, thank you. So let me just say to begin with, where I've cited or have some charts, resources. I tried to, in this presentation, have them footnoted so you can see where the information is coming from. And my usual other comment is to say that any of the opinions or observations that are made are those of the author and do not reflect that of the exchange or of FTAC or other organizations I might belong with. This gives kind of an overview of the topics I'd like to cover briefly, and they're kind of structured in a way that will hopefully mirror the thematic areas that we're going to be asked to look at from the Universal Healthcare Commission, especially with respect to benefits, reimbursement, and eligibility. So next slide, please. This is another quick slide, just as an FYI, that when we talk about Washington's health programs and what we used to call the medical assistance programs, really there's kind of a family of 5 programs. One, there's the Medicaid program that we're going to focus on today. There's a Children's Health Insurance Program, which is also a federal program that's greatly in line with this. There's the Children's Health Program, which provides coverage for children who are not citizens. We're going to have a new immigration health program that's going to be implemented next year. And finally, there's the Medical Care Services Program. Those are all the family of programs that the Healthcare Authority administers. Our focus is going to be on Medicaid today. Next slide, please. So I'm assuming, let's go through this very briefly. You know, Medicaid is the public program that's the primary health coverage for low-income individuals. In Washington and nationally, about 21% of all persons who have health insurance have it through the Medicaid program. Well, that's the case in our state as well as nationally. Medicaid is a key provider of health coverage, particularly for long-term care. Actually, probably the only program that does provide long-term care. The program was enacted at the same time that Medicare was, 1965. And like Medicare, Medicaid is an entitlement program, which means that if somebody is eligible for the program, the state and the federal government are obligated to provide that coverage and is not subject to budgetary constraints that might be with other programs. While Medicare is a voluntary program, all 50 states, 5 U.S. territories and DC participate in the program. One other aspect is with the Medicaid program, there was an expansion, a great expansion under the Affordable Care Act. Today, 40 of the 50 states have participated in that expansion. We expect over time more states will eventually join in that optional coverage. Next slide, please. Okay. Again, Medicaid is a jointly administered program. At the federal level, it's administered by the Center for Medicare and Medicaid Services, Center for Medicare and CHIP Services. That's the federal lead agency. They provide guidance to states through what's called the State Medicaid Manual, State Medicaid Medicaid Director letters, and Health State Official letters are the materials. States are required to have what's referred to as a single state agency, and in the state of Washington, that is the Healthcare Authority. And the contract between the federal government and a state is something called the state plan. That's a document that represents the contractual arrangement or relationship between a given state and the federal government. Next slide, please. I mentioned something about that the Medicaid program is what's referred to as a matching fund program. The states are obligated to provide a share of that match. The federal government matches also. What you see in this chart here are examples of various match rates that states are able to draw from when they're providing these programs. We have also what's called a basic federal match rate. That's the FMAP rate. That's based on a formula that looks at the state's per capita income versus a national per capita income. In our state is at 50%. The federal laws allow that to range from 50% to 83%. Mississippi is always at the highest one that I think is currently at 80%. The important thing when we're talking about these match rates for a moment, and I'm kind of go offline here for a second. Joan provided some information about the linkage between the health plan finder. It is the entry point for information that in our state is lodged in what we call ACES, is our automated client eligibility system, that underneath these eligibility groups, each of these eligibility groups can have various different match rates. Those rates and that information is assigned in the ACES process. That's where Medicaid eligibility rests. That information in turn is fed to our Provider One, so that when Provider One is making payments to providers or health plans, we know the appropriate amount of federal claim that we can do on that. And again, that's done through Provider One. Next slide, please. I think we really talked about this one already about eligibility in terms of managing that. Let me just say two things. One is that there's a series of mandatory programs that if states participate, they're required to. You can see the list of what they are. There are optional programs that states can provide, and you see them also listed here. And if you have time with that to talk about that further. Next slide, please. This is an effort to give you a feel for what Washington's programs currently provide for both its Medicaid programs and its other state programs. You heard earlier folks mentioned about Magi income and classic Medicaid. The examples of classic Medicaid on this chart would be categorically blind, disabled, and aged. Those are the two largest classic Medicaid programs in our state. And the key that we'll probably talk about later is these are the one programs that have resource or asset requirements for them. The other programs you see listed here do not. That's, I think, gonna be important when we talk in the future about how we integrate Medicaid, into our newly designed system. Next slide, please. I'd like to show this slide just very briefly because it gives an example of expenditures. The proportion of eligibility for the Medicaid programs and the expenditures associated with them. I'm going to give a quick example here, if I might, where you see that aged, category aged constitutes about 7% of the total enrollment in the Medicaid program. It constitutes about 16% of Medicaid expenditures. I think the important notion here is that this really understates the costs associated with our aged population, because something in the order of 96% of the folks in that aged category are also dual eligible Medicare beneficiaries. So Medicare is covering the medical side of it. What you're really seeing in that 16%, for the most part, are long-term care services that the Medicaid program provides to them. And that's a similar situation also with our disabled population. About 36% of the dual eligible, those folks are also dual eligible and receive their medical coverage through the Medicare program. So again, that 28% on the disabled expenditure side really understates the total cost for such individuals. But these represent what Medicaid pays for them. Next slide, please. We'll be talking later about Medicaid benefits. I'll say this: the Medicaid program far and away has the most comprehensive array of benefits or services of any health plan in our country. Under federal requirements, there's a series of mandatory benefits that every state that participates in the Medicaid program is required to provide. You see the 15 listed there. These are, if you will, categories of services. And then there's an array of optional services. And you see the 26, let's say, optional services categories. I would note that the state of Washington covers all 28 of those services or service categories. And it really covers actually more than that. And I'll give you one example that we often have conversations around. Our state provides abortion coverage for women in our state. The Medicaid program, you cannot draw federal reimbursement for that. That's prohibited, but our state provides that under state-only dollars. So you'll see for Medicaid beneficiaries, additional services that may not be covered by the Medicaid program. Our state provides those in addition under state-only funding. Okay, next slide, please. Thank you. This kind of gives you a sense of general expenditure areas for the Medicaid program by benefits. In Appendix 2 that's attached to this, there's a long litany of services and the extent that expenditures we have that are associated with those service categories will kind of give you a more rich feel for the domain of services that are provided by our Medicaid program. Next slide, please. We'll be at some point in time talking about premiums and point of service cost sharing. I will say this: the federal government, or I'm sorry, federal statute places certain restrictions on the amount of either point of service cost sharing or premiums that Medicaid beneficiaries can bear, and we'll probably be talking about that in more detail in the future. I would say today a couple of things. One is my sense of it would be this would be one area as we maybe seek waivers through 1115 waiver that the federal government may be not inclined to grant waivers if we should go that direction and need to go that for Medicaid beneficiaries. The other comment I'd make is today, the Medicaid program itself does not have any point of service cost sharing or premiums. We do have that for children in our children's health insurance program, and that begins with children at 210% of the federal poverty level. They have modest premiums at this juncture. Next slide, please. The next area I'd like to talk briefly about our payments or reimbursement. The federal government does have certain today existing payment requirements for various programs. I've tried to list a few of those out here. And I think a couple important ones are, well, two things. One is that states today are required to make disproportionate share payments to hospitals that serve a disproportionate share of low-income persons. That's a federal requirement. Our state today has something in the order of 7 disproportionate share payment programs, so we have a robust area in there. 2 other requirement areas that we'll be having to have some discussions about. One are for federally qualified healthcare centers and rural health clinics. These are clinics that are targeted to serve low-income individuals. There are federal payment requirements that set limits, if we'll lower limits upon which those reimbursement levels would have to be. I would make a claim at this juncture that a rural health clinic probably receives more under the Medicaid program than it does from commercial payers because of the reimbursement structure that states are required to provide. And there are also, again, are requirements for the payments made to managed care organizations. They have to be actuarially sound and to be reviewed and approved by a consulting actuary that the rates are reasonable. Next slide, please. I would say Washington itself also has some special payment requirements that are in place today for reimbursement in its Medicaid programs. Just a couple to keep in mind. One is that for participating governmental hospitals, we have a certification of expenditure program that pays for the full costs. It's a program that we use to be able to leverage local dollars to pay hospitals at higher rates than we would otherwise. Our state is elected to pay what we call critical access hospitals. These are hospitals of 25 beds or less that are in rural areas on a cost-based reimbursement. That's an optional one, but our state has embraced that. And we also, for tribal health clinics, pay the tribes at what's called the IHS all-inclusive encounter rate. And that amount is higher to a tribe for services than would be if they were serving commercial payers or Medicare beneficiaries. But when we're going through talking about analysis of payments in the future, this is an area that we'll also need to pay some attention to. Next slide, please. Last comment I would make would be, and this one would be, is that Washington, well, let me just say in general, states began in the early 1990s to move from a fee-for-service system to a managed care system. Today, all but 6 states have their delivery systems are managed care. Our state is one of those. And nationally, over 75% of all Medicaid beneficiaries are enrolled in managed care delivery systems. And I would just say again, the rationale that states have gone forward with regarding managed care is it's been a strategy to control and be able to predict future costs because the state reimburses plans on a per capita basis rather than a unit basis. It's been argued that it can account for better outcomes and support through the use of a managed care delivery system. And there's been a thinking, at least in the past, that using managed care networks may provide better access than would be through a Medicaid fee-for-service system. These are the theory that why states have moved that direction. I would say today that the evidence with respect to access to care and cost containment is one that remains under discussion. I think there continues to be a debate as to how effective at times managed care plans have been for a given state's Medicaid program. And then the last slide, if I might. Oh, yep. This is the other one just to show on Washington, the managed care penetration in our state by these eligibility groups. And as you see noted here, Washington has the 12th highest managed care penetration rate. The next slide, please. I'm trying to go through these quickly here. I'm sorry I'm doing this. I always love to show this near the end because I think one of the things that is often said is that states may not do as good a job about managing their Medicaid programs as elsewhere. And if we look at this on at least on a per capita basis or per member basis, as this chart illustrates, I think the state Medicaid programs, this is national data, has done a reasonably effective job. If we look over this time period, as you see in this chart, on overall Medicaid reimbursement on a per year basis, on a per enrollee basis, has increased at less than 2%, as opposed to the commercial or private market, which is about 3.6% per year average, and the Medicare program at about 2.8% per year average. And where you see, if you will, the great issue that I think states have to wrestle with respect to the Medicaid program and its budget impacts is not so much on a per capita basis, but the growth in caseload enrollment, people coming onto the program. And in our state, again, we have a little over 2 million people enrolled in the Medicaid program today. The last slide, please. Thank you. So these are my sort of takeaways from the presentation. One is that unlike Medicare, there is a potential pathway to incorporate the Medicaid program into a state administered unified system, and it's through an 1115 demonstration waiver. I think earlier we heard Roger Collier talk about the fact is that he has some concerns about the 1115 process. It is the vehicle that would afford for this. I think what Roger was trying to share with us is to say, our state's going to have to demonstrate to CMS that we can administer such a program in a condition for granting a full such waiver. The other comment is that, as we've talked about, Medicaid is a categorically eligible program. There are something in the order of I think, about 65 various categories, subcategories of eligibility in the Medicaid program. I think one of the good things about this is that, as we talked about earlier, the state is able to use the health plan finder as the main conduit for that. The other issue that I guess I would like to say is, where's my last comment there? That the Medicaid program has a complex array of payment systems. And I think one of the things that we'll maybe talk about shortly is the need in looking at when we bring Medicaid into such a system is to do a detailed analysis to understand what that means, because it's going to have impact on different provider groups than we might think about otherwise. So it's going to require a careful analysis. And as I said before, Washington uses a managed care delivery system. If our state, in the process of saying, as we develop our system, is it going to have carriers participate? Yes, no. If it doesn't have carriers participate, that's going to have some implications for how we handle the Medicaid program, because today, as like with the exchange and the qualified health plans, it is a carrier delivered system. So I'll stop there and ask if there are any questions. I didn't see my clock going, so hopefully I made my time for a bit.
Roger, I think you set a record for getting through a really complicated Medicaid presentation. That was phenomenal. I think we have some extra time for questions and could potentially ask Joan and Melissa questions as well, if any of the committee members would like to raise anything. I'll give people a minute to think. Christine.
Yeah, I wanted to raise a question about sort of the process. You know, if a 1115 waiver were to be adopted, it seems like you would have to require people to submit or collect information on eligibility in order to catalog for the federal government what the payment should be by these fairly, as you showed in your presentation, fairly detailed categories. And I'm guessing that would have to be done for everyone in the state. And the reason I think that is that, if you require extra collection for some people, the default might just be to say, I'm not bothering to provide that information because it's a big headache, to provide pay stubs or whatever is needed. And then you would run into the situation that you might not get reimbursed for the folks who are truly eligible. And I'm just wondering, what is it, have you thought about that, and what would be a solution to enable that without being very cumbersome?
You raise a great point, Christine. And let me say, in my personal opinion, while we certainly, I believe, have a vehicle through the 1115 process, the reimbursement aspects, the match rates I was talking about, etc., would need to stay in place. I don't believe that the federal government would just say, we're going to give you a blank check and go forward. Quite frankly, I wouldn't want us to do that, because I want us to keep the federal government, or I would recommend us, on the hook for their fair share of reimbursement for Medicaid beneficiaries. So I think one aspect would be is we have a system today through the relationship with the health plan finder that goes into this ACES system that Joan was kind of showing in one of her charts that structures all that in place. And then we have a claiming process today with ACES, the provider one, to go then back to the feds to be able to claim those federal match rates. My view would be is we're going to need to keep that in place in one form or another. But I think on the front end, with respect to beneficiaries, we can make that, as we are doing today with the health plan finder, as transparent as possible. And one issue we're going to have to wrestle with is the issue around what they call classic Medicaid. This gets a little bit in the weeds. It does have resource or asset requirements to it. And the question would be is, can we get around those requirements? I believe there is a way we can handle that, which is really of another discussion. So I think we can make it more simplified and yet still meet CMS's claiming requirements. Hopefully I'm answering your question on that one.
Right, thank you.
Thank you.
Let's go. David.
Yeah, Roger, thanks for that fantastic overview, and thanks to Melissa and Joan as well. In that match claiming process that you just described, is CMS paying its match percent of the premium that HCA and Milliman have set for the MCO payments for the year?
Yeah, there's kind of two buckets. There's what they call services or program expenditures, what we pay to providers. And there's match rates associated with different groups based on their eligibility. For example, in the expansion that under the Affordable Care Act, today our state receives a 90% match for adults in that up to that 138% of federal poverty level. There's a different match rate for what they call classic Medicaid. I lost track of what I was trying to answer your question. Those are based on services rendered. There's a payment made that comes back into the system, into provider one, and then it divides let's say $100 payment, it knows who Roger is, what eligibility he's in, and he then provider one assigns the correct match rate and the dollar amount that the state will come and draw back from CMS for that amount. And that's done on a quarterly basis through something called a CMS 64 report. And again, that system is in place today. So I don't see that presenting insurmountable problems as we look, into the future of this consolidation effort.
Got it. Thank you.
Yeah, thanks. Other questions? Eddie?
Roger, great presentation. A lot of information to cover. But when you were talking about the federal FMAP, and so when you were to look at bringing in the self-insured and the private employers, you would make the assumption that those federal FMAPs and all their flavors would continue, or would there be a new version of an FMAP for that group?
No, Eddie raised a good question. For individuals we've drawn further into a state, this consolidated program, we would not claim federal dollars for them. I use an example. Let's say in a hypothetical, which I always like to talk about, if we merge state purchasing, that we brought state employees, school district employees, and Medicaid into a consolidated state effort, which in theory we could do, we would only claim federal dollars for those individuals who are Medicaid eligible under the existing Medicaid eligibility criterion. But as I say again, we do that today on this back-end system. So while it's complex and we have kind of an arcane system, it's working, and I think we could certainly continue that.
That's good. And a follow-up on bullet 5, the rate normalization. Can you explain that term?
Yes, that's a great one. Today, Medicaid is, as I think we all know, pays less than does Medicare, and certainly less than does commercial. One of the questions that's always been brought up, if we are moving towards a consolidated system, we would want to have all providers paid, providers pay the same amount regardless of the eligibility group, be this person who is a Medicare beneficiary or Medicaid, or if you will, private. The provider of record would be paid the same. We wouldn't differentiate payments amounts. So rate normalization is an effort to say, well, what does it mean to bring Medicaid up to Medicare rates, to kind of normalize those two, and or what does it mean to bring Medicaid and Medicare up to some level that would be mere what is paid in the commercial market. And the state of Oregon kind of went through this example in their healthcare task force, and they sort of came back and said, we're going to do a hypothetical. We're going to bring Medicare and Medicaid up. Now, I forgot the exact number. It was sort of like 110 or 120% of commercial rates. I beg your pardon. They would bring it up to 120% of what Medicare is today. And they in turn would, in theory, in this rate normalization, bring down the rates that they would otherwise pay for commercial or private payers. So it's bringing all those rates together in a standard fee schedule or payment amount. I have a feeling I might be clear enough trying to say that. I'm sorry.
No, that's great. That's a big topic and quite interesting. But yeah, thank you for that.
Okay.
Bob?
Yes, thank you. A great presentation, Roger. I just had a couple of points and also maybe a question or two. First, this whole idea of Medicaid payment levels I read later on, and this comports with my understanding. When you add in supplemental payments, Medicaid amounts that are sent to providers are approximately about what Medicare pays. So I think that should be considered, not lost in the discussion. so Medicaid pays lower, but there are all these supplemental payments that providers get. So in essence, Medicaid reimbursement is about what Medicare pays. The other thing is, I think Medicare, from my knowledge of Medicare and also the healthcare system and the hospitals, Medicare pays what efficient hospitals should get based on what their costs if they're operating efficiently. The problem is hospitals don't operate efficiently in the United States. So any question about bringing public payments up to commercial levels is really counterproductive from a policy standpoint, because it would be subsidizing this inefficiency, which is incredibly high in the American hospital system. So that should, the idea of just equalizing payment, while it's a potentially great thing to aspire to, it's not something that should be done or could be done or could be afforded. So I wanted to make that point. So normalization of rates, I think should not be something that's a priority at this point, if it means bringing public payer payments up to commercial, because the commercial benchmarks are way too high and they reflect inefficiency, gross inefficiency on the part of providers in the United States. And then the last point is more of a question. I know you had a slide on MCOs. I really question the appropriateness of the use of MCOs for some of the reasons that in the public comment about MCOs, how they've oftentimes default to denials as opposed to really managing care. Have there been national studies on the effectiveness of Medicaid MCO programs versus Medicaid programs that don't have MCOs? Because my bias is, and having witnessed this in Maryland, is MCO programs add a layer of administrative costs and other complexities without really doing much of value. So that's my bias, and I just wanted to get your thoughts relative to those comments, and particularly the MCO question.
Yeah, thanks, Bob. Let me add another point to what you mentioned about hospitals. What I was trying to also emphasize, in not only with hospitals, but a variety of other areas, I keep using FQHCs, excuse me, rural health clinics that are an important delivery system. They also pay at rates that are actually, they're equal to Medicare. And I just, on its face, I know they're higher than what commercial payers would pay to them. So there are these examples. That's why if we're looking at this whole issue of rate normalization, it's a complex one, because there could be winners and losers in that. Let me say one other thing. When I was talking about rate normalization, I didn't mean to imply, if I did, my apologies, that would mean that you'd bring rates necessarily up to commercial. If I said that, my apologies. I'm thinking that there's, in theory, I'm just using Oregon. They said, well, we're going to go after a benchmark level. I think it was 120% of Medicare. Whatever it was, the point of normalization, at least for the Medicaid program, would be able to, to bring up to whatever, policymakers defined as what should be the benchmark rates to reimburse providers. And then to your point about managed care, I think that's a great one. I'm not aware of any studies that have been done that have looked at trying to compare access, cost, and quality, those nebulous areas of saying, how does Medicaid managed care compare to programs that are administered, let's say, on a fee-for-service basis. I myself to date haven't seen any of those types of evaluations. I personally would argue that it's certainly worthwhile doing. And one last thing, if I might, kind of an interesting different model is the state of Connecticut. They, I think it was in 2011, I'm losing track of time. They got in a fight with their managed care plans, and the governor said, "To hell with you. We're going to get out of the business," and they did. But what they did do is an interesting model. They didn't have the capacity to administer a program, so they contracted with 4 administrative service organizations to help them manage the program. I can go in more detail on it later on. My point being, it would be an interesting comparison to look at, well, how is Connecticut doing, for example, in this ASO type model versus, kind of a group of other like states. I know you have to, that's struggle to find out what that may be, and just to look at what their experience has been. That would be certainly one example to kind of try to get at the good question you're raising.
Yeah. Hey, Roger, I'm going to jump in now and get Liz back in this conversation
Thank you.
because she's supposed to be facilitating our questions. And I think we're starting to move on from just questions to you to things that we need to know more about. And definitely kind of the effectiveness of MCOs in the Medicaid space, I think is a huge area. And reimbursement models as well. And then I know that I saw other hands up for questions, but I think we can weave those questions in as we think about kind of next steps in terms of what we're taking to the commission.
Yeah, thank you, Pam. This is such an interesting conversation. And I just want, these are some of the questions that the UHC has identified. And I just want to we can go through these, but I also appreciate what folks are saying here. And I think the sort of main thing I would like to throw out to the group is that we know we need to have another conversation at least about Medicaid. We're going to be having more conversations about provider reimbursement. It's part of our, work plan in terms of how we're trying to stage things. But for now, what are the most important things that you as a group want to be able to tackle and discuss around Medicaid? We've heard a few things, the value of MCOs. I think in terms of trying to answer the question about eligibility though, and like similar to the conversations that we had with Medicare and ERISA, Medicaid is a huge chunk of the population. Are we kind of knowing that there are issues around trying to get matched and things like that, are we thinking about this as kind of a starting place for where we want to go rather than something that we would try to supplement and match up to? Just curious, what are things that you all think would be helpful to talk about at our January meeting? And along the lines of what we were already discussing just now. I think one question we have is, does anyone know of a comparison of benefits for Medicare, Medicaid, public employees? Christine, go ahead. Sorry.
Yeah, no, just to your first question on what to discuss. I just think the logistics of retaining the match could be tricky because people may just not provide the paperwork that they need to provide, and then you run into a situation where you can't get the match on them. So I would say that's important to consider how to do that.
Yeah.
I see one. Oh, go ahead, Pam.
I was just going to say, Liz, I'm assuming you captured the question about MCOs.
Yes.
That would be really disruptive to change that. But on the other hand, we need to know what the effectiveness is.
Yeah. All right. And I see one of our UHC members is here, Jane.
Hi, Liz. I just wanted to offer up a couple of things. First, Pam, on the MCO question, the example that a lot of folks are using of a state that's left Medicaid managed care contracting and shifted back to primary care case management is Connecticut's Medicaid program. So might be interesting to take a look at that. And then I think in talking about provider reimbursement, it would be helpful for the commission, and I think the information that we're going to have in our December 1 preliminary report may be helpful on this, is when we talk about provider reimbursement, Bob, I'm not arguing at all about the fact that when it comes to hospitals, all the supplemental funding that's available through DSH and CPE, et cetera, brings them up to Medicare. But to the extent that there still are independent practitioners and a whole bunch of non-hospital Medicaid providers, maybe it makes sense to sort of not just think about what do we do with all providers in terms of input from the advisor from the FTAC. Is it a matter of looking at what you do for all providers, or is it a matter of looking more selectively on the assumption that the state would be able to retain access to all the supplemental dollars that are floating around now? Hopefully that's helpful.
Thank you so much, David. David, yeah.
Thank you. I think having a chance to talk more about MCO effectiveness would be great, particularly since I work at one of the MCOs. I don't think, though, that it is essential to the question of a universal system, because you could structure a universal system in a fee-for-service world or an MCO world. To me, I think one of the more interesting questions is the benefits, with Medicaid having no cost sharing. If benefits are going to be uniform across all markets, that's a big deal to have no cost sharing in every other market, because I'm assuming that we wouldn't advocate to have cost sharing on the Medicaid side.
And I think at the same time, I think one of the key points of Roger's presentation is that it's hard to take Medicaid benefits away, if not impossible. And so I think those two pieces are actually quite important to keep in mind, that the idea of including Medicaid means that when we've made decisions about Medicare and ERISA, saying that we're going to try to bring it up to match Medicaid, or match the universal plan, if we're designing around Medicaid, there are going to be implications for that. And I think that is an important point. I think it sounds like folks would like to talk about the value of MCOs, and some really good suggestions have been made about things that we would want to talk about that. And the delivery system model or provider reimbursement is something that we're going to be talking about next year. So I think for purposes of what we're trying to get out right now, talking about the benefits and understanding barriers for folks in Medicaid, understanding what's going on in Medicaid is where we're at right now.
And Liz, do you know, I thought I had read in one of the UHCC's reports within the last 2 years that there was an estimate of the cost of rate normalization.
They did. Yes. The Universal Healthcare Work Group, which was the precursor to this, they did in their actuarial analysis suggest a blended rate across all different, Medicare, Medicaid, commercial. I can't remember, maybe Gary, because he has like a photographic memory, or Jane or somebody else will remember exactly what percentage it was. But it was trying to basically mitigate the fact that how whatever rates are contributing in terms of access.
When I think having the detail underneath that estimate is going to be important, because since the state has a 50% share, if the reimbursement rates for Medicaid are going to come up, that's going to be a state funded expense.
Roger.
So can I run through just a couple of suggestions to add to this? So on the area of benefits, this is is there a comparison between Medicare, Medicaid, blah, blah, blah. My response today is there is not. We did this in the past, and I would strongly recommend that there be, lack of better words, an actuarial analysis. Explain what I mean by that. That looks and compares Medicaid, our Washington Medicaid program, with Medicare, with the other example would be with state employees, SEB and PEB, which are essentially the same. The exchange, what is currently in the exchange, and I guess ideally, if there was a good example of in the large group market. And rather than just kind of looking at this at a high level, that this would be a fairly robust analysis. Our actuaries do this stuff all the time, so that we get a real clear read. We being the Universal Healthcare Commission, on where these various programs are today. I also think it's critically important because as the commission starts to think at some point about, well, what is going to be a uniform benefit design? I know that's for another day's discussion, but this background actuarial analysis would give them a great deal, I think, of important information to be able to anchor their discussion. So I would strongly recommend that. Kind of gets into the recommendation aspect. I'd say one other thing about Medicaid for just a moment. In my own view, you can have a benefit design that's not as broad as Medicaid is today, and those other benefits. The best example is long-term care, which we're not going to get to for a long time. Those can be handled as supplemental benefits in a separate delivery system. So the fact that Medicaid is broader than will be anything, in my view, at the end of the day, does not pose insurmountable problems. We've done this in the past, so that's okay. I think it's worth going back through this second one on cost sharing, if I might, on that, just to go back through and be sure we have an understanding of the Medicaid limitations on cost sharing and premiums. To do that analysis, I would say again, in my own judgment, I am not sure that CMS would let us waive those. But you never know. That's going to be a hard one. Maybe depending on what administration is in place at the time. And we've talked about on the area of rates. And here again, I would recommend over time that we have an actuarial analysis that looks at Medicaid, Medicare, and let's just say what we're paying today in SEB and PEB, which is kind of a proxy, if you will, for, quote unquote, commercial rates. And what the analysis do, this is kind of a follow-up to Bob's comments, of kind of looking through this in some detail to see where Medicaid fits in among all these aspects and what the implications of that are. And I'll give you a good example that I fear about. If we were talking about something of a rate normalization, that could have major impact on rural areas because Medicaid pays more to rural health clinics than does commercial. And I would argue that both Medicare and Medicaid pay more to small critical access hospitals in rural areas than does commercial. In fact, I kind of know that's the case in some other work. Now, my only point of that is to be that type of analysis, that detailed analysis can say if we're moving conceivably payments around, we'd have a much better sense about the implications across provider types and geographic areas.
So I hear comments or suggestions that we need to have some actuarial analysis comparing the existing programs, both kind of benefits wise, but also rates. So that we have a fuller picture. Okay, and then also more information about the limitations around Medicaid in terms of cost sharing and premiums. I heard, okay.
Yes.
Okay, and I heard Christine, your comment about, that we need to maintain match. We're going to have to run folks through some type of eligibility system, concerns about people making sure that they do the paperwork and things like that. Also heard Dave talk about the MCOs, and then we heard a lot about Connecticut. And then I think, Roger, your comment about, I think, being able to explain to folks dividing up, sort of the LTSS suite of Medicaid from the MAGI population, that there's a way that's actually currently being done right now in our state. So
yeah,
two very different delivery systems, and understanding a little bit more about that there is a path forward there perhaps too. Okay.
Liz, I wanted to jump in on one thing
Sure.
that I'm interested in, which is, I think we heard from Joan just kind of about what the Health Plan Finder does to make things as seamless as possible for people. But there are still lots of schisms and cracks between all the different programs and eligibility levels. And to the degree that there's anything to be done, but probably this would be a near-term thing, which is smoothing those out. And the other is similar to Connecticut, is what experience can we look to from other states? I think Massachusetts has been a real leader in terms of doing some things that kind of combine low-income programs. So that they're able to, first of all, get more leverage by having a larger population, and also make those programs more seamless. So if there's any potential there, I would be interested in that.
And that was definitely, thank you, Pam. That was one of the questions that the Universal Healthcare group asked was, what have other states done to expand eligibility using 1115? More recently, it's been used around delivery system reform, but before ACA, I think that was one of the main ways folks we're expanding eligibility was with distinct populations. We did that with our bridge waiver for basic health. So any ideas about states like that? Roger, I see your hands up that are doing that now.
Yeah, I would say just on what states are doing on the 1115s, CMS and Kaiser has some great information that we can draw upon that looks at the 1115 waivers in detail and say, are some states doing 1115 waivers in a directionality? I mean, we can summarize what they're doing. I mean, it's there now in a directionality that kind of speaks to what we may be thinking about. So that information it really is readily available. I'd be glad to help you round up because I know where it is. And
yeah.
One other quick thing, this back to a comment that Pam was mentioning. Pam, I'm also belong to a group called Healthcare for All Washington. You've heard us, the group, do their advocacy work. And
I have heard of that group.
Yes, you have. I mean, you know, and to a great recommendation that came from Pam that went to FTAC that was then submitted to the Universal Healthcare Commission. Our organization is going to be requesting a proviso study this coming session to look at, lack of better words, Medicaid exchange auto enrollment, the issue that you had raised before. So we're going to be asking for a proviso study on that. And I would add that California has already begun to do that. So we have a real-time model in this proviso study, look at to see how California has approached that and what lessons we can learn from them in that effort. And the point being is to try to make the system, as you're pointing out, more seamless and not lose people that we clearly are losing coverage.
And I think that I don't have it right in front of me, but the transitional solution buckets, one of them was auto enrollment. So very much in, part of the short term for the long term. So anyway, I'm going to turn it back over to you, Pam.
Okay. Thank you so much for this conversation. Has everyone had a chance to say what they need to say? Because we actually have a little bit more breathing time here. I think we have. I think, first of all, I want to congratulate everybody for getting through all that material and just in very, very efficient time and for the really robust discussion. So what will happen next is that basically, behind the scenes, the staff and Liz and Gary do a huge amount of work to consolidate our discussion and bring it into a really kind of coherent report that we can bring to the commission at their next meeting. And then we will bring that to them. There will be an in-depth discussion, and then there will be a response back to us that we can, we will dive right into in January. I see one more hand. David, did you have something?
Oh yeah, sorry, Pam, I was a little slow on the draw.
That's okay.
Since there was a lot of negative energy around the MCOs, I just wanted to say, I think it is important to ask those questions and to do that examination. I think there are some valid reasons why prior auth criteria exist. For example, this morning I was at a Washington Health Alliance meeting and we were talking about the Milliman waste calculator, and there are procedures that are done where 95% of those procedures shouldn't have been done according to clinical guidelines. So I think it'd be great if we could, if we're going to come back to the MCO effectiveness discussion, I think it would be great. I don't know that we need to have that discussion in order to achieve what the commission is trying to achieve.
I think that's helpful, David, and I think you probably would have a lot to contribute to that as we circle back to that conversation. Roger, did you have something else?
Yeah, just want to add to David's comment. I'll say on the issue of managed care versus fee for service. I'll be agnostic for the moment, but I would say that in my prior experience and belief is if you have a well-defined contract with carriers and you aggressively manage and monitor that contract, I think much can be done. And I'm just trying to use the example of concerns around, prior authorization. And there's perceptions that there is undue denial of services. Well, under a contract, you can collect that information. The Healthcare Authority, in fact, does on a quarterly basis and should be doing detailed analysis of that. And if they're finding aberrant behavior on plans, then they can, so deal with the given plan on that. And if it's not aberrant behavior, then it is what it is. So my point being is a well-managed contract can, I believe, do much to deal with some of the concerns that folks have around managed care plans or carriers.
Yes, I agree. Yeah, I do keep thinking about the person who was denied an immunization for COVID, but I think that we heard from early in the meeting. But I don't want to go. We won't go into that now. As I was saying, we will bring this information back. There will be a robust dialogue between FTAC and the Universal Healthcare Commission in terms of where we go next on this topic. I think we have a lot of heavy lifting to do before we get to kind of final recommendations. And so this is our last meeting for 2023. When we come back next year, we'll be discussing work plan in addition to the dive into Medicaid, and also our new cadence of meetings where we will have the potential for interim discussions. Our next Zoom meeting will be in January, and staff will be forwarding next year meetings invites. So please keep an eye out and please work with us in terms of any conflicts or any concerns about that. Any last words, comments, anything from staff? I think historically, we will be adjourning 3 minutes early. I don't think that's ever happened with us, with this group. So thank you very much, everyone, and look forward to seeing you next year.
Pam, thank you.
Yeah, thank you.
Thank you.
Take care.
Thanks, everyone.